Today we'll speak about critical appraisal for prognosis. Prognostic study, one of the common type study for prognosis and the survival. This is critical appraisal worksheet for prognosis, started by PICO, patient, intervention, comparison outcome, relevance, validity, result, and applicability. How they develop a prognostic paper? Started by population. Any prognostic study need large sample size based on inclusion and exclusion criteria called cohort. Cohort means group of people. They have same characteristic, same patient characteristic. Then we divide the patient into exposed and non-exposed. We'll follow the patient for future for development and the non-development of this outcome through the period of time. We have two types of prognostic studies: retrospective part and prospective part. The common type is prospective part, starting from risk factor and follow up the patient in future for development of the disease. It is good for rare risk factor, and it can predict and calculate the incidence and give us large information and strong information. Need long time follow-up. The classical example of prospective cohort is اللي هو Framingham score. Framingham score for 10 years risk for development of coronary artery disease. Retrospective cohort, looking for patient with the development outcome. Development of disease occurred already, okay? Then retrospectively go back to the file of the patient and looking for the exposed and exposed person. Critical example or classical example is corona. Go to the patient with the corona, develop patient with the corona, and retrospectively look the file. What is the most common cause of death in the corona patient? For example, renal failure. Retrospective cohort one is recalling bias, is one of the common type bias of retrospective cohort. Prospective cohort اللي هو ال drop out bias, common type of bias for prospective part. Validity. This is the question of validity of prognostic paper available in worksheet. What are the representative well-defined sample patient similar point course of the disease? Was follow-up sufficient, long and complete? Were objective and bias outcome criteria used? Were the adjustment for important prognostic factor? I will simplify this validity and the prognostic paper. Validity, the common study design is cohort study. This abbreviation RIOVA, representative sample. This sample is representative for the community and taking the patient in early stage of the disease, okay? This is called the representative sample. Cohort means group of the patient, they have same characteristics. This is representative sample. Then inception cohort. We mean by inception cohort, taking the patient in early stage of the disease. Outcome should be defined at beginning of the studies and should be detected at beginning of study, plus blind assessor to prognostic factor. If there is no blind assessor to this prognostic factor between two groups, lead to the bias, which is called diagnostic bias. Diagnostic bias. Follow-up is critical and important part of diagnostic paper. If there is loss of follow-up, lead to drop out bias, or another name called attrition bias. Attrition bias. Adjustment of prognostic factor. Adjustment of prognostic factor. This is a specific statistical method for adjustment of prognostic factor by called regression analysis, which joins between dependent and independent variable. If there is no representative sample, lead to the referral filter bias or selectivity bias. Same name. If there is no representative sample, lead to common type of bias in the prognostic paper called referral filter bias or selectivated bias. This is very important point in the validity. I will review it. And first of all, representative sample, and if there is no representative sample, lead to referral filter bias or selectivated bias. Inception cohort, taking patient in early stage of disease, outcome defined at beginning, and blind assessor to the prognostic factor between two groups. If there is loss of the blind assessor, lead to diagnostic bias. Loss of the follow-up lead to iteration bias or dropout bias, and should adjustment for prognostic factor. Taking patient in early stage of disease, which is called inception cohort. In all prognostic paper, at least two exceptions for this rule. First of all, in the smoking cessation, we can take the patient already enter in the smoking program. Okay, we accept this patient as inception cohort. Second exception, if you choose the patient, for example, at moderate stage of disease, all your patient at moderate stage of disease, for example, cancer, we can accept this rule as inception cohort. Only two exceptions for this criteria. I will explain here some common bias for prognostic paper. Referral filter bias. As I told you, severe cases will refer filter to the tertiary care because it needs special expertise. In the prognostic paper, to avoid the bias, we need to choose the patient from the community at early stage of disease. Don't take the patient from tertiary hospital when the disease and outcome already happened. Take the patient from your community, from primary care, from ER, okay, to avoid referral filter bias. Second, lead time bias and the length time bias. What is the difference between these two bias? Lead time bias, survival. In prognostic paper, we talk about prognosis and survival is measured from the time of the diagnosis. Maybe increase not because the patient longer, but because screening lengthening the time that they have a disease. Classical example, prostate cancer. Most of the patients die with prostate cancer, not from the prostate cancer, from another reason other than prostate, okay? Because lead time bias, because prostate cancer, slow growing tumor. The patient life with the prostate cancer without any complication, maybe die from another complication, for example, cardiac disease, DM, and so on. Length time bias, rapidly progressive cancer will be less likely to be detected by screening test. And there is no screening tool for this type of the cancer if the symptom rapidly develop. For example, pancreatic cancer. Pancreatic cancer is aggressive, progressive, growing tumor, can kill the patient in the 6 months. Okay, it's called length time bias. In the prognostic paper, we should differentiate between two terms: risk factor and prognostic factor. What is the difference between these two? Risk factor related to the development of the disease, mainly bad outcome. But prognostic factor, as I told you before, prognostic factor is patient characteristic, weight, height. It can predict good or bad outcome. Kaplan-Meier curve, the result of the prognostic study can represent in the Kaplan-Meier curve, or called another name survival curve or predicted limit estimator. Another name for Kaplan-Meier curve, survival curve, product limit estimator. The difference between the risk factor and the prognostic factor from the patient outcome and event rate. Risk factor starts with the healthy patient, okay? Prognostic factor started with the sick patient. Outcome, onset of the disease. Then the outcome and the prognostic factor, consequence of the disease. Event rate relatively minimum and event rate relatively high. Hazard ratio, as I told you before, the hazard ratio is the relative risk. It's odd ratio, same thing. But in the prognostic paper called hazard ratio. The definition of hazard ratio is relative risk, the same. Relative risk associated with the prognostic factor over the period of time. This is the difference, over period of time. Then hazard ratio mean is relative risk associated with the prognostic factor over period of the time. Calculation of hazard ratio is the same. L over C, event rate over control rate. But here say the risk ratio of outcome in group with the prognostic factor to the ratio of the same outcome in group without prognostic factor. This is the validity of the prognostic paper. Now the result. How large the likelihood of the outcome event in the specific period of time, then how precise estimate likelihood. This is the Kaplan-Meier curve. This is the, to explain for you the component of the Kaplan-Meier curve. I started to comment on any Kaplan-Meier curve, comment on the name of the curve and the author and date of publication and the reference of this curve. Okay, this is the Kaplan-Meier curve or survival curve or product limit estimator. This is number one. Second, this is the control group. This is the red line, show the control group, and blue is treated group. Then اللي هو at beginning of curve, this arrow show the start of the study in both control and the treated group. This is the end of the study in both control and treated group. Started of a study in both group at, for example, 25 days. End of the study in the treated group 150 days, and same in the control group. The comment on the shape of the curve, step up or step down. Okay? Then we should calculate two things. This curve is study the relationship between the percentage of the survival or cumulative risk or development of outcome and the time. Day, month, week, years. Okay? We have two things to calculate it. Median survival rate. Median survival rate, it is the started, look to the arrow here, median survival rate. Median survival rate. Mean اللي هو المنطقة هذه median survival rate started from the 50% death. When the 50% of the population died and the 50 of them still alive, this is called median survival rate. Then send this arrow to here, to the treated group, around 60 or 70 days. This is median survival rate. Opposite thing, which called, for example, 125-hour survival rate. Survival rate started from the time, not started from the population, from the survival. Then you find this is equal around 80 survival rate in the control group and 60 in the treated group. This is the Kaplan-Meier curve. Another example of Kaplan-Meier curve, survival curve of the outcome here, severity of atherosclerosis. إذن هنا الcumulative risk is atherosclerosis. This curve compare of the three grades of atherosclerosis, grade 0 and 1, which is dotted line, and grade 2 This is continuous line, and the high dashed line اللي هو grade 3. Okay. Then the B value is put it for each result. Now, in this Kaplan-Meier curve, the grade 3 severity of atherosclerosis is cumulative survival rate more than grade 2 and grade 1. That's mean grade 3 is more severe complication than grade 2 and grade 1. Another type of the curve which is continuous linear curve. طبعا هنا the B value is significant. This result in this curve show the B value less than 0.05, which is significant in the grade 1 and the grade 2. Another curve which is continuous curve, month and the percentage of the event. This is risk reduction, relative risk reduction, and the B value, and comparing causal for hypertension and the placebo. Suppose this event rate is improve or control of the blood pressure. Now we can find the causal control blood pressure than placebo. Okay, and the relative risk reduction 16, and the B value significant. Can the result applied to my patient? Same systematic review, same therapy. Ask yourself about, does the patient, same setting, available of the medication, important outcome can obtained from these studies, and are the results useful? This is an addition here in the prognostic paper. Are results useful in reassuring or counseling your patient? The one difference is reassuring and the counseling your patient. By the end of this lecture, I will ask MCQs about prognostic paper in the cohort, prognostic study, the time of inception cohort mean, selection of patient late time of target disease, selection of patient in early time of target disease, selection of patient at any time of target disease, or selection of patient in different time and stage of disease. The answer is selection of patient in early time of target disease. This is the MCQs general review for all type of the studies. We need the interaction from you. First of all, match following statement to relevant answer. High sensitive test, low 1 minus specificity, hazard ratio, publication bias, small confidence interval, B value less than 0.002. Another side, funnel plot, rule out of disease, precise result, significant result, and survival curve, and the rule in disease. First of all, high sensitive test, what is the answer? Rule out. Rule out of disease. Okay. The low 1 minus specificity. What does it mean by low 1 minus specificity? It is decrease false positive. Decrease false positive. If the false positive decrease and the specificity. And what is this? Okay. Rule N. Then hazard ratio. 5. Survival care. Publication bias. Funnel plot. Small confidence interval. Precise. B value. Significant. إذا الفانل بلوت اللي هي D. Rule out of disease A. Precise, which is small confidence interval. Significant. B value less than 0.02. Survival care in the publication hazard ratio. Rule out of disease اللي هو low false positive and increase the specificity. We can rule of the disease out. Any questions? Thank you very much.